So someone comes to you, and I actually am someone that could be coming to you right now. Actually, they come to you and say, hey, my shoulder's been bothering me. What are the first things that you kind of sit down and consult them with? Is it sending them down to the sports medicine team to do some stuff? Is it going directly to you, other doctors first? Like, how does that typically work?
That's a good question. I mean, we get this all the time, and we call them often curbsides, for example. But if you come into the clinic for a consult and you say, hey, I've got right or left shoulder pain, the first thing we do as physicians, regardless of if you're a surgeon, is we really want to take a history and say, okay, hey, when did this start? How bad is your pain on a scale of 1 to 10? What makes your shoulder pain worse? What makes it better? What have you tried so far? Overall, if your shoulder, if a normal shoulder for you is 100%, what percent of your shoulder is yours? And so we try to get a good history on your shoulder.
So the brief history then, if we're walking through it, it was around January. I got sick, probably rushed back in the gym a day or two early and tried to incline Smith press 225. Not smart. I could feel it on one rep. It just felt a little weird. Tried to do some shoulder exercises. Just got out the gym that day. Let it rest for a few weeks. Thought it was getting better, but ever since then it's been kind of a level 2 or 3 pain nonstop. I've worked out again, but I'm working out around it, trying to strengthen it, doing mobility exercises, but it's still a constant pain. Yesterday I actually went golfing. And my buddy was like, hey, your swing looks weird because I was bending my arm more than normal. And he's like, go back to straight. And I did. And when I did that, I think naturally I was bending it because when I'm straightening it back, I could feel the tension in my shoulder. So that's kind of been the brief rundown of what's been going on there.
Okay. And so then we would ask, are you right-handed? I'm assuming
Yes.
you're right-handed?
Yeah.
Okay, so it's your non-dominant side.
Yep.
And then this happened while you were benching. Was it on your way up? Was it on your way down? Did you feel a pop?
Believe it was on the way down. No
Okay.
pop, but it was enough where when I got off, I felt it just really, really stiff.
Really stiff.
And like I said, when I tried other movements after, I could just tell it was time to cut that day.
The second thing that we'll do is we'll do a physical exam. And so from the physical exam, we'll do an inspection, we'll palpate, we'll feel where are there areas of point tenderness, do a range of motion exam, look at different provocative tests that may or may not be positive, and then do a good neurovascular exam. So I'm going to just make sure we're not missing anything else. So I'll touch this joint right here, which is called the SC joint. And the AC joint will kind of feel along the back of the scapula and the back of the shoulder. There's no pain. And once we've done our point tenderness one, now we'll start to do a physical exam on the range of motion part. And so we always want to compare it to, quote, the good side, because most people just typically have one problem on their shoulder. And so we'll check your range of motion in different planes, which is really good. And then we'll check the abduction. Nope, that's okay. Go there. And then how far can your arms go behind your back? It's pretty good. Awesome. And so your range of motion is normal. Okay, it's very symmetric to the other side. And now we'll test some strengthening. And this is how we test the rotator cuff. We typically internally rotate, keep the thumbs down, and then we start lifting. We ask you to resist me, so lift up against the ceiling. And we test one of the rotator cuff muscles there. And then we have you put your elbows at the side, and then we have you push out against me. And then we put your hands on your belly and bring your elbows out so that they're straight, and then you resist me. And so all of your rotator cuff muscles are full strength. We grade this like between 1 and 5 typically. 5 out of 5 is normal.
Right.
So now we've done your range of motion exam. And now what we'll do is we'll do the provocative tests. So certain tests are positive with certain diagnoses. Sometimes you get positive tests for different or multiple diagnoses. And so this is where the shoulder becomes a little bit of a gestalt. And so we'll let it relax and we'll do this. This is really for impingement, which means that if there's a bursitis, which you're not complaining of any pain, so that's not hurting. Now I'll go and start touching the areas where you were hurting. And so it's right in there, so that's where your pain is. So that's where your biceps tendon resides. Okay, so now I'm thinking, okay, maybe you irritated your biceps.
Gotcha.
And now we'll bring your elbow out here, and now lift up against me. Does that give you any pain? A little bit? Yeah. So that's called a speeds exam. We'll go across your body. I felt a little click there, so that may be your biceps. Again, lift up against me. Does that hurt?
A little bit.
A little bit there too.
Yeah.
Okay. So that's just an abbreviated exam. We would do a
Right.
shoulder instability exam where I typically have you lie down and we put your shoulder through a range of motion and kind of feel the translation back and forth.
What are the most common shoulder injuries that you see on a day-to-day basis here? whether it's how it was injured or specific areas on the shoulder? What are the most common ones that you see?
So the most common shoulder problems that we typically see are rotator cuff tears. We'll see a fair amount of shoulder arthritis. And we really try to break down these pathologies into two groups. And it's really kind of younger patients and trying to define what is that age or that cutoff for younger. Maybe it's 40, maybe it's 45, maybe it's 50, versus older than that age group. And those two that I just discussed, the rotator cuff tears and shoulder arthritis, are typically seen in older patients. And the reason being that these are degenerative findings. They happen with time. If you look at the incidence of rotator cuff tears, we have lots and lots of studies that show that, more than 50% of people over the age of 65 will have some sort of rotator cuff pathology. Shoulder arthritis is becoming more and more common because people are active for a longer amount of time. They're doing more and more active things at a younger age for longer periods of time. In the younger patient population, probably the most common shoulder problem we see is shoulder dislocations and sometimes some fractures, just because of the mechanism of trauma from a sporting injury, sometimes a car accident, something like that.
So what are some things that if someone is just, let's say, an average gym goer, maybe they play some sports on the weekends, they're in their late 20s, early 30s, maybe even in their 40s, and they start feeling some sort of discomfort and they're not sure, they can't pinpoint, when it got hurt. What are the things they should be looking for before they decide it's time to go to their primary care physician or even come, to a place here like Banner and really start getting it looked at?
Another good question. So unless there's been a real mechanism of injury, so in the younger patient that we're talking about, a fall, a car accident, some sort of kind of traumatic mechanism, a lot of these tend to be overuse, or they might just be like, hey, I aggravated my biceps tendon, or I aggravated my rotator cuff, or maybe, I had a partial dislocation doing something. And so kind of a good general rule of thumb is if this thing is lasting for more than a week, despite some rest, some anti-inflammatories or over-the-counter pain medication, I think a consult is probably warranted. And that could be with the primary care physician initially, could be with somebody like me. But I think if it lasts for more than a week, despite rest and some anti-inflammatories, I think it's probably a good idea to see someone.
You touched on the importance of preventative. I know here at Banner that's a big focus, but in your field, surgery happens. So what is post-op typically? Like let's say it is a rotator tear cuff as an example. What does it look like? Because I see people, when you go on Reddit or Google or whatever, not the best place for answers, of course, but people are always concerned, if I have shoulder surgery, I'll never get mobility back. So what are the things that you see or recommend or push people into to kind of, if they have to go through a surgery on their shoulder, whatever the injury is, they can recover on the other side as best they can?
So this is really, really great. We answer this question all the time because, and I'll preface this by saying, when we turn on the local news, we tend to see all the negative stuff. Right. And so we see all these car accidents that are happening and they're awful. But we have millions and millions of people that get in their car and go to work every day and everything's fine. And so unfortunately, the press that we see about surgeries, whether it's the shoulder, the knee, something else, whether it's not even orthopedics, if it's orthopedics or not, we always hear about kind of the negative and the complicated cases or something that went wrong. But the truth of the matter is the majority of these actually do well. And so that's the first thing I try to hone in on is that, a huge percentage, and I'm willing to say between 80 and 90% of people do very, very well with shoulder surgery. And specifically with rotator cuff tears, we know that 80% of these are degenerative. And what that means is that very few of the rotator cuff tears happen acutely. We'll see like the electrician that falls off the ladder, he's 40 years old and has an acute rotator cuff tear. That happens, but that's kind of in the 20% category. Most rotator cuff tears are degenerative over the age of 65. That tendon has kind of become thinner. It's like a beat up shoelace. And then the blood supply to where it attaches to, it's not the best as we age. And so then you have this degenerative tear. So what we're doing is we're going in and we're fixing and we're taking that tendon, putting it back down on the bone, and really hoping that that scar interface is strong enough to be able to allow you to start having motion and so forth. And so the components of really having a good outcome are a few things. Number one is recognition of the right diagnosis, or a rotator cuff tear. having an experienced surgeon, whoever that may be, as long as they've got experience, to really fix it in the right way. I think compliance post-operatively, so that typically consists of a sling for a few to 6 weeks post-operatively, and then a really good therapist that understands that pathology. So not progressing you too fast, but not letting you fall behind. And so we all have different types of protocols to where we can mitigate and decrease shoulder stiffness, enable improved motion, and this way people can get back to doing what they want.
Is there anything else that I didn't ask you that you would like to just get across to anybody watching and listening this today?
I think shoulder replacements are relatively new when we talk about joint replacements. Hip and knee replacements have been around for a long, long time. I think in the last 10 to 15 years, we've really understood the shoulder mechanics. Our advancements in technology and instrumentation have really advanced that field significantly. We're much, much better at these. Our medium and long-term follow-ups are really great. And so I would just encourage people that if you have been diagnosed with shoulder arthritis, please seek a consult with a shoulder surgeon, because there are some treatment options, and I think the type of education that you'll be provided will really open your eyes.
What are some of the things then you've seen on shoulder replacement that have just gotten progressively better over the last 10, 15 years? Like, what is it specifically that's made this more of a viable option, I guess?
So a couple of things. I think the advancements in instrumentation have allowed us to get access to the shoulder a little bit better. I think we're more precise in terms of where we're putting our components, because we're really leveraging technology. So CT scans, preoperative planning, virtual and augmented reality, a lot of these things exist in the shoulder. The types of implants that we're using, they're continuously being modified and adapted. We're able to restore some of the biomechanics of the shoulder so that the natural shoulder biomechanics are restored. And then I think lastly, fixation. We're just getting better and better at fixation and really minimizing the need for cement unless it's in certain revision cases.